Hello, everybody. Thanks for your kind introduction. Thank you to join us for this session. It's a very hot topic session, and what we can do for ACL rupture in young female patient, and especially the French experience, but also the international experience with different group research. I would like to thank first the Hospital Innovation for its involvement in education. It is a very important thing, and I thank them very well. Also, SBM company to develop and help surgeons with the different devices, and especially the pull-up device. So let's start with the ACL reconstruction in young female patient, and I would like first to have a background for the different concepts I've been supporting for a long time. You can have in your mind these three concepts before to start to take care about ACL rupture. These three different concepts are very, very important. For some of you who were present in the first session, I already presented this concept, but I would like to do it again. First, it's the link in the chain concept. We'll see it's very simple and very important thing, but we will see that few people consider this concept. The second is a la carte surgery concept, and the third one, which is the new one, it's a benefit risk ratio concept. We will see what is this concept. First, that's the link in the chain concept. Everything is resumed in this draw. You see that you can fight a lot to increase the resistance or the property or the quality of one of your link. I mean, for example, for surgery, you build up your technique, you do very big thing. That's only one link, and it close to this is your patient selection or return to play decision is not good. You will have a failure even though you fight to increase one of your links. So the conclusion is you need to reinforce every link in the chain. That is very important, and we have so many links in this chain. You can see that the surgical link are a few part of this, and it's not a limited list. You can have a much more link if we think a little bit more. And you see that the patient selection is very important thing, lesion assessment and rehab program and return to play decision, what kind of laxity we have to repair or reconstruct. It's very important thing. It's so a la carte surgery concept came from what we observe every day in our practice. So it's injury circumstances are different for every patient. Some has got valgus injury, varus, rotational injury. For some patient, it was hyperextension traumatism. But also energy and kinematics are different. I mean, that's, for example, in the southwest part of France, we have got a lot of rugby players. They are heavy and very sport guy, and you can imagine that is high energy people contact activity. So you can imagine a big traumatism can provide a lot of lesion, not only the ACL lesion. Also, the patient morphotypes are different. We've got hyperlax patient, heavy patient, and structures lesion are different. We will see this later. So, in conclusion, each case is unique. And from this, we think that there's no way for a standardized treatment. We have to match our technique, and we're taking care of patient for every patient. It is a personalized and a customized treatment, not surgery. Treatment is unique for each patient. This concept is supported by a very important thing. It's the concept of primary and secondary restraint structure. it was described long time ago by a very important team, the MES team in the Imperial College of London. It's the most important team in the world that described this concept long time ago, 2004. That's what is primary restaurant structure. The definition is the structure which is the most parallel, not exactly parallel, but the most parallel of the displacement we consider. Displacement should be AP translation, but also rotation or valgus or varus direction. So it is one direction and the structure which is the most parallel. That is the primary restaurant structure. For example, ACL is a primary restaurant structure for the AP translation because it takes care about 85% of the AP global forces, we can see in this draw on the right. And the secondary restaurant structure are the structure less parallel to this direction. And you can see on this draw that, for example, the MCL, which is one of the peripheral ligament, it is not really parallel to the AP translation, and we see that it is less parallel than the ACL. So it is a secondary restaurant structure. That means that if the primary restaurant structure is ruptured or stretched, that the secondary restaurant structure will support this constraint. And of course, because it's not parallel, it will be stretched little by little. Other structure which very important in this secondary restaurant structure is the capsula itself and its thickness in the concept of ALL complex. The ITB is very important, and don't forget the menisci. Menisci are effective in the laxity control, and especially in the internal laxity, excuse me. The lateral meniscus, it's very important in the control of the internal rotation of tibia. So that means it is included in the ALL concept, many lateral meniscus and the sorry. And the medial meniscus is important in AP translation. So that means if you remove your posterior corn of the medial meniscus, you increase your laxity. So think about taking care about this menisci. It's important not only for the osteoarthritis in the past, but also to help the other structure to control the AP laxity or rotational laxity. Don't forget the menisci has a secondary restaurant structure, not only the ligament. Okay, so. When in case the primary restaurant structure is damaged or ripped, you increase the constraint in the secondary restaurant structure, and it becomes lax little by little. And if you don't repair this, you will have global laxity, and we know that all lesions are very difficult to control because every structure is stretched, and it is a much more complex surgery to repair, to return to the normal thing. So before to have this kind of damage, repair or reconstruct your ACL or the other secondary restaurant structure. I recommend you the lecture of this very important paper published in 2015. They always this team, this UK team, study the knee laxity with a robot, as you can see, in different angulation of the knee. That means that a primary restaurant structure at the full extension should become a secondary restaurant structure at 120 degrees of flexion. The concept of primary or restaurant structure is related to the knee flexion. So it's a very important thing. It's not the primary restaurant structure for all the degrees of flexion, all the conditions. If it could change, you have to consider the knee flexion. And remember, look at on this tab, that for internal rotation, the ITB is the primary restraint structure. Much more than the ALL. As you can see, the ALL is not the primary restraint structure. That will be very important. I will tell you at the end to decide what kind of surgery you will do. Remember this. So we always underestimate the secondary restraint structure. I used to say to the youngest, you are the generation of the secondary restraint structure. My generation and the previous one underestimated. We just focus on the ACL. But it's not enough. If you want to go further and to get better results, we have to consider this structure. They are always present. They need to be considered. You have to make them heal before or during the ACL reconstruction, and that is the important effect to brace the patient. Even though you think that they have isolated ACL structure, but I promise you that it doesn't exist. Brace your patient for a few weeks. You will help the healing of the secondary restraint structure, and your ACL reconstruction will be better. Sometimes, if they are very damaged, you can repair them in the single stage surgery. I would like to prove this by this picture. Look at this picture on the right. This is an MRI lateral view of the knee. You see the bone bruise. The bone bruise are the result of a very strong contact in between the two bones. And if you match this bone bruise zone, you see that the femur was in that position at the time. So I drawn the MCL structure in the A position, and you see that the same structure during the time of giving way is much longer than the A distance. That means that even though you have isolated ACL rupture, you see that the MCL was stretched minimum. So think about that. All the patients that isolated ACL rupture doesn't exist. So we need to repair and reconstruct the primary restraint structure before to have much more lesion. Think about that. So a la carte surgery concept is based on meticulous assessment. But for the moment, we don't have exactly the good and the right tool to objectively assess the laxity. It's just a clinical assessment, and we are not the best in this evaluation. It's too much personal. But if we have a perfect tool, we are working for that, but not for the moment. Probably we will be better in our indication. And the patient morphotype also, it's important in this a la carte surgery concept. Different morphotype of patient, kind of patient, level of sport. So with our toolbox, we could match this patient statute with what kind of surgery we can propose, and probably in the future we will tell to the patient after an objective assessment of every parameter. You know, you got this kind of lesion, and for you, the better treatment, that's statistically the better treatment is this one, and that will be the future of ACL reconstruction. That is the third concept I've been supporting. It's a concept of benefit-risk ratio. What does it mean? It's based on the surgical treatment. What could be the adverse event related to your surgical technique? Because we do surgery, but of course we have a complication or adverse event related to our surgery, and that will lead to the graph shows what kind of modification we implique and use with that. We will see later, and the incidence of degenerative lesion. All these parameters will have an important effect on the shows, and especially the graph shows. So before choosing one technical surgery, think about what we got and use depending on the kind of patient, depending on the kind of sport. It's not it's different. For example, for a football player or dancer, it's not the same thing, and the effect, the risk we have to harvest one graph should be different, and the technique should be different. So now return to our hot topic, and the young female patient. What is the specificity of such a patient? First, it is the age. It will be different if it is a kid or teenager or young adult. This kind of patients are mostly hyperlax patients. That's a very important thing. That means that the collagen and the tissue are very elastic. The collagen is composed with a majority of elastin protein. But it's like an elastic. It's difficult to control stability with an elastic thing. It should be better with a stiff structure for the adult or this patient. Also, the kind of sport for this female patient. In Europe, we have a lot of handball player, female handball player, which is a pivot contact activity. It is very aggressive and very difficult condition, mechanical condition of knee behavior. Also, this young female patient has got a valgus deformity, which is another complicated thing regarding the giving way and the pivot shift. So the first parameter is the age. What is the difficulty considering the different age? It is related to the growth plate status. First, with open physis patient, use a specific technique to preserve the growth plate, because more the patient is young, more you can have a complication with the growth plate, and sometimes alignment deformity. You can do surgery with no tunnel crossing the plate. We will see. It should be one option. But if you choose an option to drill through the plate, you have to consider you need to do small tunnel in the middle of the plate. You don't have hardware bridging the plate, such as a screw, for example. Don't use BTB because it is a hardware. If you bridge the physis with the bone plug, you will have deformity. So use a soft tissue for such patient, no BTB, and save the remnant tissue in order to help your graft in the healing response. ACL repair should be considered. We will see, should be an option with a scaffold or not. For the patient with close wedge statute, it's not a difficulty. It's the same technique used for the adult. That's the four techniques you can use. On the left, the transphysial ACL reconstruction. It's the technique I prefer because it's the same I do in routine for the adult patient. But you can have also two different options with physical sparing reconstruction with over-the-top technique. But you see that it's not very isometric, and we know that it is a difficult surgery with bad result, and if we introduce a non-isometric structure, probably it should be not very effective. The other option is drilling the tunnel in the epiphysis, so under the physis, It's not easy to do, and also the isometry should be difficult, and fixation also. No, in my hand, the best way is the left one, is a transfiscal ACL reconstruction. What about repair? Repair is it's an old concept, but it's a new fashion, and you can use a scaffold or autograft. Martha Murray, a woman ACL surgeon, very renowned, based on Boston in the US, proposed in 2010 this technique using a scaffold, a biological scaffold, to bridge your rupture, because she shown through many different studies that if you don't bridge your lesion, you cannot expect any ACL healing. That's impossible. You have to bridge this. It is another topic. We could talk about this another time, but you have to bridge the lesion. You can bridge it with the scaffold, as she do, or with an autograft, as proposed recently. And this kind of surgery is that is a concept. You do a standard surgery using 4ST and suspensification both sides. You have to insert your graft from the tibia to the femur. No way for the all-inside technique, because you will be unable to save your remnant. So you have to go from the tibia to the femur. I stitch the remnant, and I put this through the femoral suspensory fixation, and I tied it from the tibia, and it is very nice, rather complex, but very nice to do. It is a complex. I drill the tunnel inside the remnant, and I track the graft and the remnant, and that is some view. You have on the first slide in A, the first picture, ACL heel on the PCL. So I detach this remnant from the PCL. I stitch it, as you can see, and after introducing my graft, I tied it above and around my graft, and you see that is a better view than the A picture. In B, you have a structure completely covered with vessel and nerve captor. I think that could be a very good option, but we have to assess this with time. It's a new concept. What about hyperlax patient? Two things to consider. First, in hyperlax patient, you have the risk of notch graft impingement in the last degree of hyperextension. So in that case, to avoid such impingement, which could be degrade or damage your graft, place your tibial tunnel a little bit posterior, 2 or 3 millimeters. But if you do this, you will change your graft isometry. So don't forget to put your femoral tunnel a little bit posterior to save the isometry of your graft. But after your reconstruction, cycle your graft and check the graft behavior. And if you still have graft impingement in the roof of the notch, you can do a notchplasty, a small notchplasty. Additional reconstruction should be helpful in that case of hyperlax patient in order to aim the functional result. But because if we miss the anatomical result, and we have a laxity, remnant laxities, we have to aim the functional result. That means we have to control the internal rotation doing lateral reconstruction. And that is, in that case, remember what I said with the MS publication in primary and secondary structure. If you use ITB for your reconstruction. For example, to do lateral tenodesis in this patient, you will damage the ITB. And remember, the ITB is the primary restraint structure of the internal rotation. So in that case, don't use ITB, use a graft to reconstruct the ALL concept, because you add something and you don't damage your ITB. So that is the benefit-risk ratio. You have to consider this to choose your technique. Save what is a native thing. You can add something, but don't remove another thing. So that is the construction I propose to reconstruct in the same time the ACL and the ALL complex. Sorry, I use a 4ST with a standard process and 2 suspensory fixation. One thing different, that I use a pull-up XL on the femur, because the femoral tunnel is complete, and I link a free gracilis graft for the lateral reconstruction, for ALL reconstruction. It is a rather good graft, as you can see in this picture. You see that the ALL reconstruction is rather good quality and long enough, and it is linked to the 4ST with pull-up text. It's the structure which link the two graphs. That means that the structure are completely independent, and your ACL reconstruction is working itself. And if the ALL reconstruction fails, you won't have any bad result on your ACL reconstruction. But that is not the case with some other technique where the graft is continued. If some fail, it induce and lead to failure of all your reconstruction. So that is very interesting, because it's a very good graft, quality graft for the ALL reconstruction, and independent thing. They work separately, and you don't change anything in your standard ACL reconstruction. You just add something else. That is how does it work. You introduce the graft and all the system from the tibia to the femur. You lock the graft and insert the ALL reconstruction under the fascia. You return to the tibial tunnel. This tunnel position is situated just behind the Giardi tubercle, not in the middle of the fibula and the Giardi tubercle. I think it is much more too posterior. If you want to have a good effect on internal rotation, put it a little bit anterior, just behind, posterior to the Giardi tubercle. Okay. One thing it's important, one link it's very important in the chain is the rehab protocol and the different kind of sport. Remember I said that for this young female patient in Europe, handball sport is the most frequent activity, and consider the prevention program. And recommend you to use this smartphone application called GetSet. It was developed by the Sweden people. It is a free application. You have different kind of sport. You can tell the patient, follow the list, and choose your different program. There are at the end different movies showing different program for rehabilitation and prevention. That could be very helpful. They use that in prevention before injury, but it could be included in the rehabilitation program. It's very important to prevent new traumatism with such rehab protocol. So it's very important. Tell the patient, download this smartphone application and follow or to the physio and follow the different exercise you will have to do. Another option is a very new, a surgical option this time, is bracing your ACL reconstruction. What does it mean? That's remember, I say that for such a patient, the collagen, and of course your graft is composed with the majority of elastin, and it is elastic, so we have to make it stiffer. How to do this? Using an internal bracing. That means that's linking your two pull-up with a pull-up text. You tighten at the end, and so you see that you have a rigid structure from the cortex, femoral cortex, to the tibial cortex, and the graft is brace, is help in its healing by this structure. It should be temporary, but I think that the time of healing, it's a very important time. So that is how does it work. I prepare on my tab my two pull-up, and I use BTB pull-up. I remove the plate, and I insert this structure in the two loops just close to your graft. And you see, after an insertion of the graft, I tighten my graft, and I cycling my knee, and I check. I see that my internal bracing is still loose. I tighten it. You see, it's very effective, and this gonna save the length in between the two pull-up during the healing time. It's a new concept. I don't know if it will still remain continue, or I will have a rupture, but anyway, I think it's important to protect the graft during the healing, especially for this young female patient. Last thing, it's the specific cases for this young patient. There's the spine ablution for the youngest, and it is a very helpful and very tricky technique using the standard pull-up. You take the standard pull-up, you enlarge the loops, the buckle, and you put your plate at the other end. Put a suture, an additional suture in green in the draw, the last draw, in order to avoid the reduction of your two loops, and you will use an additional thing called the pull-up clip, put on the bridge on the tibial side. That is the technique. You have your spine ablution. You clean out all the injury zone, remove the piece of bone and the blood. You reduce your fracture with the hammer, and drill a small tunnel, 1.5 millimeter. It's a very small tunnel. You don't need to drill a very big tunnel. So after that, you insert in this small hole a suture relay. With this suture relay, you will pass your system in this small tunnel. You reduce the fracture, you insert the pull-up clip and tighten this, and you will have a fixation which is in the direction of the ACL, and it is completely different compared to the screw. If you put the screw, you will put your bone, a piece of bone, a little bit posterior. And with this system, you track it in the direction of the ACL, and you have a very good reduction without any residual laxity. That is the picture we can have on the X-ray, and in the arthroscopic view is very nice, and we have a very good result. And after a few months or years, you can go back to remove this plate if you want. It's very easy without any problem. So that's what I would like to tell you regarding this complicated patient and its taking charge. I thank you very much. It's I think it's very specific because with some technique of ACL reconstruction, for example, in adults, when you use a BTB, you have to go in a full extension because you can be anxious regarding the lack of extension. But in the hyperlax patient, not. I recommend you to fix the graft at 25, 30 degrees of flexion or more, because you will, it's impossible to have a lack of extension in such patient. So don't be anxious to fix the graft at 30 degrees or 40, 45 degrees of flexion. It's internal bracing. It's a new concept. We don't know a lot regarding this. I mean, it's a new concept. It's just 5 or 6 years we consider this. So we don't have a lot of good result of this. So I think that we have to do our technique complete, tight your graft, check the cycling behavior of graft, and at the end, tight your internal brace. Not before, because if you tighten your internal brace before tightening your graft, you can reduce the length, and in that time your graft won't be tightened. So the first step is to tighten your graft. Then, as you saw in this movie, in my movie, tighten your internal bracing after. But beware to don't use too big internal bracing because it should be foreign body inside your knee, and you can have a reaction, inflammatory reaction, and in that case you will compromise your graft healing. So there is a ratio to consider in between the graft and the internal bracing. Don't put too much brace, because if you do this, you will return what we did in the past. It was a prosthetic ligament with a very bad result, with bad results on the inflammatory response immediate, on the chondrocyte health and healing and different things. So okay for internal bracing, but rather small and non-aggressive device.
Is there a size internal brace that you'd recommend, Philippe? Or
no, I don't have any data for this. It's simply the good thing. I use this pull-up because it is a small structure with a very strong efficacy. We tested this in the lab, and I reported in the previous conference that we have with the pull-up 850 Newton resistance. So it is rather good with a small structure, but the ratio between the size of your internal brace and the mechanical property seems to be good. Of course, we have to go slowly with the rehab protocol with such a patient, and we have to consider two different things. In one hand, you need to load your structure and your graft if you want lead to a good healing. If you let the patient in a brace or on a cast, of course, it's not good for the healing of the graft. You need to have a constraint to stimulate the healing, but not too much, because if you have too much aggression, too much aggressive rehabilitation, you will have mechanical tension on your graft and you will stretch it. So it is the good balance in between these two options. So yes, for rehab protocol, but no regressive protocol. Protect your knee with the graft. Do a long program of rehabilitation with a prevention program, and the time to return to play will be much longer than the standard patient. It means that no return to sport before 1 year or 18 months. Yes, it is, and you have to implicate the family and the staff and to explain everything to all the people involved in this treatment. It's not only the patient, all the chain, the team, the parents, and you have to explain this, and it takes a long time. No, sincerely not, because it is a very small structure. Sometime in some very thin patient, because of course in this part of the tibia you don't have a muscle or fat tissue, and for some you can feel the blade sometimes, even though in the standard ACL reconstruction, but we don't care with this because, first of all, it's very small, and you can wait 6 months, one year, and after healing, you can propose the patient to remove. I did that for 6 patients in my cohort of 1,500 patients, and I removed after 1 year or 2 years the tibial blade because patient have got some pain without any issue or any problem, because it's just a temporary fixation. After healing, the blade and the pull-up is not effective at all. So you can remove it and stay with a stable knee. So because it is a small structure, even though you could have some pain, you can wait for a while and remove it after. Of course, if you have a rather long remnant, when the rupture is very proximal on the femoral site, and the remnant is complete, it would be better. But sometime it could be shorter. For example, in this case, healing on the PCL after cleaning this and putting a suture, it is two-thirds of the native ACL, sometimes the half part. But we don't care with this because I told you that the important thing of this is to breach the rupture. You put something and the nature gonna grow up along this. What is important to consider in this concept is first to save structure and to tighten it to the femoral direction, because if you don't do this and you save remnant, sometimes you could have a retraction of your structure and a cyclops syndrome. This kind of technique, putting the remnant in the femoral direction, first of all, cover the most you can your graft, providing vessel and nerve structure in order to improve the healing response, but also you avoid the cyclops syndrome and the retraction of your remnant